My name is Ravi Vij. I'm a professor of medicine in the section of transplant and hematological malignancies at Washington University School of Medicine in St. Louis. I think as far as COVID-19 goes, we're in the beginning phases of learning how this will impact our ability to deliver care and its impact on the treatment for our patients. Certain places in the country are certainly experiencing a spike in the number of cases and have much more stressed resources. In some cases, physicians, specialists as well, and there the implications of the COVID-19 on cancer care delivery may be different than other parts of the country where the spike has not yet occurred to the same degree, and one has been more successful in flattening the curve. I would say that what we have certainly seen is that the inpatient units are these days being emptied of patients that do not need to be in the hospital. We are trying to delay elective admissions for procedures like stem cell transplant as far as possible, but there are other situations, obviously, where patients need their treatment because they have active cancer, and those are proceeding according to previous plans. We are continuing to do allogeneic transplants as well. Certainly, what has been now formulated is a policy that you need to make sure that the donor's product is available on site before you give them the chemotherapy, because sometimes either delays in obtaining the product in transit or some mishap with the donor's health may be detrimental in proceeding with a planned transplant. So you want to make sure the product is on site. In the outpatient setting, we're certainly trying to use more telemedicine and telehealth. We are trying to decrease the encounter between patients and healthcare providers face-to-face so that they are not exposed to multiple sources of potential COVID-19. But what we are continuing to do is treat our patients, and so far, at least in the part of the country that I am in, there hasn't been any need to delay treatments for our patients. We still have the supply chain intact to deliver the therapies that patients need on time. For our patients, certainly there is less of a face-to-face interaction with members of their healthcare team. This has been replaced by telemedicine and telehealth. It certainly doesn't have the same ability to be personable, and in a field like cancer care, where emotions and interpersonal interactions are a vital part of care delivery, that certainly robs us of a vital element of providing care. Another impact for patients has been the inability of caregivers to accompany them to certain areas of the hospital, and in certain institutions like ours, a policy of no family member being present in the patient's hospital room during their stay has certainly impacted patients' ability to have a caregiver to help them cope with some of the more challenging times in their treatment. Some of these patients, unfortunately, do get sick and even end up in ICU settings, and then the non-availability of a family member is something that is jarring to the family members as well, that they cannot be near their loved ones. Worry and anxiety is a natural process of human emotions that everybody is experiencing, not only patients, but even caregivers. I think that we are trying to employ all our resources. We are, as members of the healthcare delivery team from the oncology perspective, readily available in terms of answering patients' questions, either through the e-medicine EMR portal or through the phone. We also are trying to make sure that anybody who needs the counseling services is able to do so. The counselors are available these days, mainly again using telehealth and telemedicine portals. They are not able to come to a patient physically, but hopefully it at least provides some level of reassurance and help for our patients. I think these are trying times for everybody, and we do need to work as a community to improve the results. Partnerships that have existed even in the past, in the pre-COVID era, whereby pharmaceutical companies and other stakeholders in the healthcare delivery system have worked to hold symposia and have both healthcare worker directed and patient directed delivery of educational programs should continue their efforts. It may be that we may have to go virtual and once again use the portals that are increasingly being used, like Zoom and others, to have these kind of conversations. I think that each specialty in oncology has going to come up with its own ways to tackle the problem that is going to be with us for at least several weeks, if not longer. We have guidance that is being developed by various professional organizations and societies to help guide therapy, and I think that we should all try to keep ourselves educated and in communication with one's colleagues to learn best practices to help patients along. I think that in my own specialty, I have already mentioned that we are trying to decide in certain patient populations to delay stem cell transplantation, and in others where patients are doing well to perhaps increase the interval of treatment between therapies that require them to make visits to the office of physicians. But certainly in situations where the cancer requires treatment, we cannot let up and we need to do everything in our ability to deliver care